Hi, I'm Kheya Furtado, Associate Professor of Healthcare Management Program at the Goa Institute of Management. Together with my faculty colleagues, we have been conducting embedded implementation research for the Ayushman Bharat Pradhan Mantri Arogya Yojana, the largest publicly financed health insurance scheme globally, in collaboration with the Alliance for Health Policy and Systems Research and the World Health Organization Country Office for India. Our work so far has focused on two key themes that are of interest to policymakers. First, the organization of strategic purchasing through public trusts versus commercial insurance companies. And second, policy interventions for improving the quality of care under PMJAY. In this video, we will tell you a little bit more about our work on quality, and you can find out more about our work on trusts and insurers in a linked video.
The purchasing agencies for PMJAY are state health authorities. These are public trusts set up for the purpose of this scheme. However, trusts have the flexibility to implement the scheme themselves or to contract a commercial insurance company to purchase the services from healthcare providers. Senior policymakers at National Health Authority were keen to understand which of these models was a better choice to make. Based on their needs and together with the technical officers of the WHO, we refined our research objectives to compare the performance of states adopting either model in terms of providing access to care and their claim management efficiency. We also compared the cost of adopting either model. Embedded implementation research requires a selection of methods that can provide valued insights to the questions policymakers have interest in. However, within the limitations of decision-making timelines, therefore, in our first study conducted a few months into the scheme in early 2019, we adopted a 6-month mixed method comparative case study design in 2 states, adopting either model. The study identified important implementation challenges with either model to guide states on improving the effectiveness of each. We summarized our recommendation and presented these to National Health Authority and to the Honorable Health Minister. You can find out more about this work in our paper linked below.
We further built on this work through a larger study 3 years after the scheme had been running and across 6 states this time. The second study helped to validate several of our earlier findings, but also provided new insights. In brief, we found that access and utilization of care was similar in both models and confounded by other factors beyond implementation goals. Commercial insurers showed better claim management efficiency than the public trusts, insofar as they were able to adjudicate a higher volume of claims and within the prescribed timelines. However, administrative costs were higher when insurance companies were involved, and there were indications that increasing utilization was likely to push premiums higher in the coming years. Contract terms between the state health agencies and commercial insurers were effective in that claims were not unnecessarily rejected by the insurance company and placed limits on their profit-making potential as well as loss-bearing risk. However, there was evidence to indicate that the earning potential of the scheme perversely incentivized private insurers to offer untenably low premium rates to win contracts, later impacting claim management and causing mistrust among healthcare providers. We recommended actuarially set benchmarks in the tenders to avoid this in the future. Our findings have implications for the choices that states make as they continue to expand PMJAY. You can find out more about this and our related works in the publications linked below.